All right, welcome everyone to the February edition of our National Ultrasound Journal Club. This session is going to run similar to some of the prior sessions we've run. We're going to spend the first half of the session gaining insights from some of the cutting edge and amazing literature that's out there from the author herself. Then we're going to split out into breakout rooms and discuss article number 2. We'll regroup at the end, talk about lessons learned, and finally, some for those who want to stay on for this, we will get some methods and stats consults. So without further ado, we're going to talk about our first article. This is a prospective evaluation of point-of-care ultrasound diagnosis of diverticulitis in the emergency department, published in Annals of Emergency Medicine. We have the honor of having Dr. Cohen, who's an assistant professor, co-fellowship director, and the director of ultrasound research at North Shore University Hospital. She's an active researcher in critical care, GI, and pulmonary ultrasound. We're so glad to have you joining us to discuss your article today. And with that, I wanted to just pass along to you and just first ask, ultrasound for diverticulitis, what prompted you to want to study this?
Okay. Hi, everybody. I'm Allie. Thanks for having me first and foremost. I'm a huge fan of ultrasound stuff, obviously, and ultrasound research. So I'm really excited to get to talk about a paper that meant so much to me and the rest of the staff here at North Shore. So thank you for having me. I guess we started this project a couple of years ago after we have a lot of residents at a lot of different places as well, and a lot of fellows. And so we do a lot of educational scans, and we started on our educational stands to sort of start to see things that we thought, bowel ultrasound looks kind of interesting to us. What could this be? And then we followed the patients up and it was diverticulitis. And then we did some research about it. And we just saw that there wasn't much out there in the literature. There's been a couple of small case studies where they say ultrasound is very good for diverticulitis. And then we saw stuff in Europe where they started using it. So we thought if they can do it there, why can't we try it here? And so we're always up for trying new things. So we started really looking at it and trying to see if we could do this. And we did like a little mini version just to see if it was possible. When we found that we could do it, then we sort of decided, let's go for it and do a prospective study. So we were really excited to try something new and then learn the new technique. And it was fun.
I love that. And it's funny because when I was training in ultrasound, bowel was this area. It was like, okay, you can sort of do bowel and they'd be like, oh, what do you mean by that? Well, you can look for the appendix and then not find it. And that would be the extent of bowel ultrasound. And then small bowel obstruction came along. You're like, okay, I can do this second thing. And the more we look at it, we're like, oh, okay, so EM, EM, we can do intussusception, we can do HPS. And they're like, what about diverticulitis? That's like so much more common. We see that all the time. And I love how you said, well, they're doing it in Europe. And a lot of times Europe is kind of leading the way in, some of the more, CT saving diagnoses. And then you said, hey, let's study here. And you trialed it out and just did it. And that's awesome. One of the things I thought was really cool is you were able to enroll a really large number of patients. And for those who have run trials, it's hard to enroll active ultrasound patients who are getting like large numbers of scans in there. So what strategies did you find allowed you to recruit patients so successfully for a study like this?
I think one of the best things that helps, especially if you're at a place like North Shore and if you're at a lot of academic institutions, is that we have a lot of ultrasound people here. So we have 4 or 5, or actually now 6 or 7, probably when I started, faculty trained. And then we have 5 fellows usually per year. And so you get that as your base trained, and then you get them excited for it. And then you start doing it around the department, then it starts to get out there. And I'm also a very big nerd and I'm here a lot. So I wouldn't recommend this, but people did call me when I was living when I was by the hospital, do you want to come in? We have a rule out divertic. And I used to come in for it too. But I think the biggest thing is just to get your team on board, because when you try to do these things by yourself, you're not going to get the numbers and it just takes forever. And then you'll be here all the time. And that's a little depressing. But when you get your staff motivated and the people you work with motivated to do this and get excited about it, it makes enrollment so much easier. And then also you get your patients excited, being like, hey, we're looking at this thing called diverticulitis. It's an ultrasound. Maybe one day I can replace CAT scans, like get the patients excited and they like to see it. Then that really motivates them to want to be part of the study as well. So we worked really hard. So we have our scan shifts that are 4 days a week, and then tape review is Fridays. So we're always here. Someone's always here 5 days a week. And then because we have such a high number and we have great PAs that are ultrasound trained as well, that are here that can scan as well for us, that when you have such a great number, it really makes it easy to enroll patients.
Okay, so step 1, hire a bunch of ultrasound nerds. Great.
Yeah.
But step two, it sounds like, is just get buy-in, like get people to see the vision. And that makes sense, right? That's how we enact change, is get people to actually buy into the mission of this is really helpful. This is useful. This is why we should do it. I think that's, while we may not have, in a massive number of ultrasound faculty at our shop, we have a lot of people who are generally interested in how do we improve patient care. And so that sounds like that really kind of helped increase your numbers as well.
Yeah, I think our faculty too were so excited by like, oh, you can do an ultrasound for diverticulitis. And once it was out to them that you could do it, then they would start, like when we first started, we were really like searching the boards, looking for people getting CAT scans, and then we'd approach them. But towards the middle end, faculty knew what we were doing. So anybody that they have, oh, I think this patient's divertic, they would call us right away. So that also helps when everyone's involved in the study and knows what's going on. It really helps to increase enrollment.
No, I love that. It's a snowball effect. If you see it a lot, it starts to build on itself. And the same thing happens when you shift seasons and the snowballs melt. If you see less and less of it happening, it feeds the opposite direction. So just building that forward momentum and some of the upfront work to build it out so that people just keep seeing, and that's just expectation. I love it. I mean, very impressive work on that.
Thank you. Well, it's really to the ultrasound division here because they're amazing.
Love that. And so as you think about this, not everyone even now does ultrasound for diverticulitis. So maybe as a just a framing point, what are the criteria? How did you diagnose diverticulitis in your study?
So what we did is, again, we kind of looked at what other people have posted or other people have written about, just to give us kind of some foundation of it. We started seeing the diverticuli pretty quickly, but then the question was, what are the numbers that you need? What are the other criteria? So we looked at mostly in the European literature and some of the case series, and what they really posted was that you had to have a couple of different things. The most important thing is you had to see diverticulum. If you didn't see that, then you couldn't really call it diverticulitis. Then they talked about this thing called hot fat, which is kind of focal fatty enhancement, which we love it here because we just say, oh, it's hot fat. We wanted to make a t-shirt, but Nelson said it was weird, so we didn't want to do it. But it's hot fat. And then you also look at bowel wall edema, which I think is the most critical part of it. And so we saw most studies use this 4 millimeter criteria. And then there were also some that used 5. So when we were designing the study, we kind of had to figure out which size we wanted to use for it. We were debating it kind of back and forth. Do we want to be more sensitive? Do we want to be more specific? And so kind of what we determined is we really want to call it if it's there, because we're like, we don't want to start people on antibiotics unnecessarily or start admit patients for diverticulitis, kind of like with appendix that we went a little bit higher than lower just because we really wanted to make sure what we were calling it was accurate. So we chose 5 millimeters and then sonographic tenderness to palpation. So you'd have to kind of put the probe there, push on that area where it hurts. And if that was positive, it was yes. So we use sonographic tenderness to palpation greater than 5 millimeter bowel wall thickness. And then we used focal hot fat, and those were in the presence of a diverticulum. So you had to have all of these things. And then we called it acute diverticulitis.
I love that. It's kind of like sonographic, McBurney sign, sonographic Murphy's, you have the sonographic diverticulitis, and then hot fat, which I will now never forget. Yeah. I feel like that needs to be like your background.
Nice little songs to things in our division. So I won't give you the hot fat song, but we have a couple coming out there. I'll look at YouTube eventually. We're going to make little rap videos.
Love it. But it's right. So it's things to help you remember it. That's part of it. That's part of how our brains work, right? You come up with a strategy and no one's ever going to forget that piece of it, or at least now, not all the people on the call today will now have the term hot fat in their brain for the temporary future, maybe longer depending on your upcoming rap video. But, it's those kind of things that help us to lay it out. And I like how you also had that thought, because nothing all sounds really tricky. There isn't always a straight yes, no, this is the answer. It's that, well, what about 5 millimeters, about 4? And you had that discussion, that decision between your team. What was your trade-off? And that makes sense why you chose 5 for the study.
Yeah, I mean, it would be interesting to look at, 4 and see if that changes things. Unfortunately, we didn't record. Part of it, our red cap, we had to hit 5 to call bowel wall edema. And if you hit that, then we put the number in. So we don't know patients that had 4 millimeters, if we would have had more on increased sensitivity for it. But it would be interesting to know, but we just kind of kept it at 5. And also 5 is a nice, easy number to memorize, although 4 is kind of the ultrasound number for a lot of other things.
That's totally fair. Yeah, no, that makes sense. And it kind of speaks to every time the study comes forward, what's the next step? So it sounds like they may already have, or a budget or a future researcher on this call may have an idea for a future study to see what happens when you change it to 4. Now, you highlight that as one of the things, thinking back, what are some of the other challenges you faced? I mean, this study, was very successful, got an Annals of Emergency Medicine. It's been talked about a lot. I think every study we learned from that. So what were some of the challenges you faced when you went through this study?
I think the biggest thing for me is I was first kind of starting out with doing research stuff. So I didn't really know a lot of the ropes and how to do things. So I think the biggest thing is just kind of looking back on it is just initially just what data are you collecting in your first study? Because I think that having to do it retrospectively after you've already finished, then have to go back and, add other variables. So I always tell the ultrasound people now that when we're doing a study is think of anything that might possibly be related to this. So we looked at like the CT scan, just the diagnosis. And then when we went back to look at it, it wasn't coded in a way that you could analyze it. So we'd have to go and do it again. So just when you're preparing your database, make sure one, you have all the variables that you need and that they're in a form that can be analyzed easily. Because if you have to go back and redo a lot of data entry, it's a big pain. And then also don't take everything on by yourself. I think it's really important to have a good team, even if it's just one other person with you, helping you, trying to organize things and get the department involved. When you take it on by yourself, it adds a lot of extra stress and a lot of extra work. So I'm really fortunate, and I know that because we have such a great fellowship here and so many great faculty that really have come and gotten really behind a lot of the research that we're doing here. But when I first started, I was trying to do it mostly by myself, and now we kind of spread the wealth and it makes things so much easier.
A lot of really key pearls in there. Part of it just being that research is a team sport. I think the first study I did as a resident, I was enrolling almost 24/7, and you're like already at the hospital all the time. And then every time a patient would come in, you're like, okay, I'm just going to drive back to the hospital. And that's not a sustainable model.
No, I did it. It's brutal. It seems fun the first few weeks when you first start the study, when you get a call, but then it's like someone calls you at 1 a.m. You're like, oh, do I want to drive? And at 1 a.m, or is that like really pushing it? But don't push yourself too hard.
100%. The other item that I really liked, I'm a huge fan of, is that downstream thinking. You laid out, how am I going to categorize things, make sure I have all my fields. Oftentimes when I'm doing a study, I'll do something very similar to what you had done, which is I'll lay out, in my context, I'll lay out a table and say, here's all the variables I want to have. And it's amazing how many times I go back to my data extraction form and I realize I'm missing a variable I wanted in my table because I just hadn't thought about it. But it's not until you're like, oh yeah, I'm going to write the paper. So it's almost like a fast forward. And you're starting to write the paper, you're like, oh, I can't believe I didn't collect this important piece of information, or I can't believe that, now I can't delineate this piece of information the way I wanted to. So it's kind of almost like a gut check. And I found that for me, it works really well, kind of paralleling some of the things you laid out too.
Yeah, I think for us, like having to go back and redo some of the data entry thing, it's especially when you have a bigger database, it's just a lot to go back into REDCap, then you have to go back into their charts, and it's just a lot of effort that could have been mitigated by just knowing it's hard because you don't always know what you want to do or how it's going to lay out, and then having to fix it is just harder. So spending a little more time getting yourself organized at the beginning, I think really helps.
Absolutely. And have you ever talked to statisticians on the studies too, and the back end, if you do simple things like numerically code it, it saves them hours and hours of time. But it's just things we don't think about because we're not on the back end of that. And so I love that, just forward thinking pieces of it.
Yeah. Our statisticians find us like when they ever review, like, how did you come up with this? I'm like, I don't know. We made up an analysis and then they have to fix everything later. So they're kind of used to us. But that's another good important point is if you have access to a statistician, try to use them earlier because they will help you so much.
100%. And so one of the things as we look forward now at this study, that it was pretty impressive. Ultrasound was 92% sensitive, 97% specific, and the confidence intervals, the 95% confidence, was actually relatively narrow. Like they were within a couple of percentage points on each item. So with that in mind, how do we interpret this in light of the study limitations? How should we be interpreting these findings?
So I think, it's definitely the biggest limitation which we have, which I think a lot of ultrasound studies have, is that it was either an ultrasound fellow or an attending who had training. So before we started this, we had little training sessions and then we did ultrasounds together. So we've seen it multiple times beforehand. And then these are, sonographers are highly trained. So they're very well aware of ultrasound. So I think our next step is to try to figure out what we can do on a residency level to get the residents more involved. Because I think we've done it where we show them the clips and then they can see it and they get that pretty quickly. But in terms of can they actually acquire those images, we don't really know. I think they definitely could, because I think residents can find an appendix, and I think an appendix is way harder than finding diverticulitis. In my opinion, I just think an appendix is one of the more, sometimes you're lucky and you find it right away, and sometimes you're in there for a half hour looking for it. And divertic is usually, they point it there and then you're golden. So I think the next step is also to see what can we generalize this to other ultrasonographers that aren't heavily trained with prior experience.
That's awesome. That led exactly to what my next question was going to be, which is what are the future research directions? So some of it sounds like is amongst how do we apply this amongst the ultrasound experts to the kind of broader population? Do you see any other future research directions that you could use this information for?
So one thing that we're working on now is we kind of nickname the mega diverticulus or megaticulus. We have to think of a cool name for it, but we want to do like kind of the ultimate goal when we started this, and kind of what I was thinking about is how to create more of like a screening tool for patients. So you can say if they have X, Y, and Z, like age, use white count or procalcitonin and whatever you want to use, or lactate, and then ultrasound findings, can we rule out the complicated diverticulitis? Because I think there's a lot of evidence now that very mild diverticulitis, you could say, antibiotics, no antibiotics, depending on your preference. But I think the biggest thing that most of us are concerned about is if we don't scan somebody, are we missing somebody with an abscess or missing someone that needs admission to the hospital? So what we're trying to develop is, our statistician told us we need 4,000 patients, so we're in it for the long haul, is trying to figure out if we can create a screening tool using the ultrasound findings that we have, plus other variables like past medical history, laboratory stuff, and age, to try to see if we can say you have a negative scan, you don't meet any of these, or you have a positive scan, but no other risk factors, you don't need to get a CAT scan. And that's our ultimate goal. So we're going to like multiple sites, multiple centers to try to get them enrolling patients as well, to try to get the volume that we need, as well as try to get more providers involved and try to really see the generalizability to other sites.
That's great. I love that downstream thinking, because we're all ultrasound nerds and we're like, this is really cool. But then no one ever uses it. It doesn't matter how accurate it is if it's not actually impacting care. So you're looking at this like patient, relevant outcomes downstream of that, which is just brilliant and so important and so needed in our field. I think some of this also lends to what we're going to talk about when we get to our second article, which is like, how do you incorporate other factors into it?
Yeah, I mean, I think for me, it's kind of like I saw like kidney stones, that we really have moved away from CAT scanning a lot of kidney stone patients now. And I think hopefully, I know in Europe, especially with like IBS and even with kids, we obviously never CT, but they're moving away. I talked to a lot of my GI predecessors that they're moving away from CTs for like Crohn's flares, IBS flares, because they know of the radiation. So if we can see that for diverticulitis, I mean, especially for the younger patients that come in, and we have a lot of them that come in here. I see like 30-year-olds with it, 40-year-olds. It's really now encompassing a lot of different age groups. If we could limit the amount of radiology, get them out of the ER faster without having to CT scan, I think that would be awesome.
I love it. I look forward to the day that it starts to parallel what we're seeing exactly with kidney stones, where the expectation is no longer they get a CT because they happen to have a kidney stone, when we know what we're going to see. And then hopefully that follows forward here as well. So I have other questions, but I'm looking at this. We have this whole group of, active and future researchers here. What questions do you all have for Dr. Cohen? Feel free to you can raise your hand and unmute and ask away.
Hey, my name's Yo-Yo. I'm one of the ultrasound faculty here at Stanford. Thank you so much for sharing this work. And I really love your Sandy Beach wall art. That's so cute.
We're definitely nerds here.
I was wondering, in terms of like moving on to this kind of mega divertic thing and looking for complications, did you guys find that you're incidentally already recognizing some of these signs in people who had an abscess or perforation when you were doing your initial study?
Yes. So we actually saw a couple of different things that kind of geared us more towards a complicated diverticulitis. So you can definitely, we saw perforations a couple of times. So part of our protocol is we looked above the liver. So we did see free air, I think once or twice, and then looking for free air within the fluid that we saw. So we saw it like a localized perforation. And then we did see a couple of abscesses. Sometimes we didn't see an abscess, but we saw free fluid there. So the things that we found that were more associated, again, we have to look, I don't know all the specifics of the analysis, is that free fluid, if we saw an abscess or if we saw signs of like a bowel obstruction, those were all associated with or correlated with signs of complicated diverticulitis, as well as free air. The other thing that we saw as well, but we still have to look at, is the degree of the bowel wall edema. So I think it was 1.1. I'd have to double check how thick the bowel wall was, if that was associated. And then if they had diverticulitis, you saw left lower quadrant pain, and then you were scanning, you saw kind of angry bowel in other places, like on the right side or in other quadrants, that also tended to have a higher likelihood of having a more complicated disease.
Yeah.
It's great. And it looks like we have another question just came in the chat from Sean Scott. Did you want to ask it or you prefer me to read it? Okay, so I can ask this. It was
Can you hear me okay?
Yep. Go ahead.
Oh, I'm so sorry. I forgot my headphones today, which is why I was putting in chat instead. But I was curious, I saw your scan time was less than 5 minutes for these studies. And when I've done kind of bowel scans basically before, it's taken a little bit more time as I try and work my way around the air that I see in the large bowel or things like that. I was wondering, I saw your protocol, like start where the pain is and then work vertically using lawnmower technique. But I was wondering if there's anything else in particular that helps you kind of keep your scan time down to a shorter time interval overall. Thank you.
So, oh no, thanks for the question. So what we did was we made sure the patients got pain control if they needed it before we started. So we always asked, is your pain okay? Like we did a quick push. And if they were in a lot of pain, we didn't start because we knew you weren't going to be able to get any of the images because if they're miserable, it's just unpleasant for everyone around trying to do it. So if you medicated them before, and then when you looked at the scan, so really we mostly focused on the area that hurt them. Once we looked at that, then we just went up and down. And usually a lot of the other bowels, you don't really see anything. So you could pretty much do it pretty quickly. And then the right side, usually you could do that in under a minute. So it was really spending the majority of the time on that area because we didn't want people, I mean, we didn't have a limit for this. When you started it, we just looked back on we recorded the start and stop times on the machine. So I think the biggest thing with any kind of abdominal ultrasound is to make sure patients are pain controlled because it's just, if they're in pain, you just can't do it. It sounded like the appendix as well. Like you just can't do it if they're in pain.
And a follow-up sort of sub question to that. Do you feel like that reduced your sensitivity for the sonographic tenderness sign? Because they talked in other studies about giving IV pain medication and that reducing either sonographic Murphy's or things like that.
So it definitely might have. I think we put that in our paper. I'd have to double check as one of the limitations. But I definitely think it might. But I think people are still tender. Like they're not gonna, but it's a tolerable tenderness. So you push and they say, I'm like, is this where you're in pain? And they say, yeah. So we included that as sonographic. It just, you could push them and you couldn't really push before.
Those are really good questions. Both. I liked how you approached that, retrospective approach to how do you identify how long it took? Because if in the moment, if you don't have a research assistant timing it, using the timestamps to check is a really clever way of assessing that. And the other point as well, in terms of just pain control, it goes back to how we used to, or not we, but before my time, how they used to hold off on pain medication because the surgeon might see the patient with appendicitis and they shouldn't have any pain control because that might ruin their exam, but that's gone by the wayside because that's just not fair to patients and miserable. And ultimately, we need to do something that's going to control their pain so they can do this in practice in a way that's actually ethical and right to patients.
Yeah, because especially with this scan, you're going to be pushing right where it hurts. And if there is bowel there, you're going to have to push some of it out of the way. And it's not feasible and it's not nice or fair to the patient if they're in a lot of pain.
Absolutely. Any final questions for Dr. Cohen before we get ready to spread into breakout groups?
I have maybe a side question. I'm Nikolai. I'm one of the faculty at OHSU in Oregon. How do you do education of your residents for this? You mentioned kind of getting the residents up to speed. And then how do you do QA? Because I feel like for a lot of bowel ultrasound, if you find the pathology, then it's easy to do QA relatively. But making sure that they did kind of an appropriate scan outside of just watching them has always been a bit of a challenge when I'm, going through these scans and QPath or echo or whatever.
So for me, what I do is I usually give them a lecture on bowel ultrasound, and then we kind of do, when they're on our rotation, we do kind of focus lectures, like mini lectures when we go through kind of what we're looking at. And then when we do our weekly QA, we go through bowel ultrasound with them. And then I have a lecture that I give to the residents usually once a year, just to kind of go through how to do bowel ultrasound. I think in terms of QA for bowel ultrasound, we are really fortunate here in that Dr. Nelson has created a very stringent kind of ultrasound policy. So if they're going to do a bowel ultrasound, the residents for education, meaning they're not being supervised by a credentialed sonographer, the patient has to have a CT. So if we see something, we have the CT scan to either corroborate it that they have diverticulitis or they don't. So which makes our life a lot easier, because sometimes we'll say this bowel looks weird, like they need further testing, because sometimes the residents don't get the whole exam, but a lot of them are pretty good at it at this point because we've been doing the study for so long. So a lot of them are aware of it. And so when and they actually really like it because they're like, oh, it's kind of new. So it's not like the same. So it shakes it up a little bit. So when they do it, they get excited to try to find it. And then it also counts for them as their tally for the year in terms of how many scans they do. So we add a little bowel category. So that also motivates them to get more experienced and more comfortable with bowel ultrasound.
A lot of really great pearls built in that one. Thanks for sharing those. Oh, good. Dr. Fox.
Hey, everybody. Chris Fox here at UC. I got my team with me. Hey, I was wondering, did you ever reach out? Have you had any interaction with the IBUS people, the International Bowel Ultrasound people? I'm not sure if you mentioned that already or not.
No, I've never spoken with them in the past.
Yeah, we reached out to them this year because they've got a conference coming up in Chicago. They go all around the world every year. They're in a different country. They happen to be in Chicago this year and end up with a conflict, but they're kind of like when I start Googling, diverticulitis bowel ultrasound, and a lot of the GI doctors get their bowel ultrasound training with that IBUS group, and they have to travel internationally to get it. I'm just wondering if we should try to kind of take the all the expertise that you're developing and try to create a more of a local expertise here so we can get a lot more people trained in this.
I would love it. Anything to get people more excited in ultrasound and to reduce CAT scans, it would be great.
Cool, great work. Great job with this. This is really interesting.
Oh, thank you.
Great suggestion, absolutely. And on that note, let's get ready. We're going to split off into breakout groups. The plan for this is we'll have Dan assigning you out into different rooms. You're going to have 1 to 2 faculty moderators. We're going to discuss the article, Prospective Validation of the Bedside Sonographic Acute Cholecystitis Score in Emergency Department Patients. We'll discuss that for probably roughly about 20, 25 minutes, and then we'll regroup for the last maybe roughly 5 to 10 minutes. When we regroup, we're going to ask that each group share one thing that they learned. So as you're going through this with your small groups, try to think of one, maybe a couple, because there's a chance the other group may say the same thing. And that way you can have someone in your group who will report that back. And with that, we'll have Dan split everyone out. And I'll see you all shortly.
Mike, I did not assign you a group.